Yeah, let's get started.
Started? Okay. Hi, everyone. Hope everyone's doing well with all the numbers going up in COVID and whatnot. This is a pretty basic overview of pumps, which the reason why I thought I know you guys did this at AHPBA, which COVID derailed my plans to go there. But Trish, who's joined me today, is actually Dr. Kemany's nurse practitioner on the medical oncology side at Memorial. And she and I have worked together for a very long time. But she's basically been doing pump chemotherapy as Dr. Kemany's nurse practitioner for about close to 20 years now, I'd say. So she really knows this stuff inside and out. And I thought, we'll go over the basics on pumps so everybody kind of is on the same page. Really what prompted this is that prior to COVID, we were getting returning fellows coming back pretty much, it seemed like once a month to bring their teams to come and see how Trish and her team handle all the ins and outs of these pumps, because it's thousands of patients and they really require close following and maintenance and tweaking and dose adjustments and all this other stuff. And Trish and Karen and Sandy, who are they're the two nurses that work with Dr. Kemany, and Dr. Kemany have been a team basically for 20 years, which is kind of unheard of. And they really have perfected it. So I roped Trish into this and I said, come do this webinar with me. I thought if anybody, especially people who are relatively in the infancy of having a pump program, you might have a couple of things that Trish could answer. I did send out a link of a good just overview of pumps. Actually, one of our fellows wrote it in the Journal of Clinical Surgical Oncology. What was it? Journal of Surgical Oncology, published in March of 2020. Basically, this PowerPoint summarizes that, but goes over just some basic things regarding pumps and what you need to think about. Of course, I'm a little bit more focused on the surgical aspect of things, but I think this will be a good overall talk with Trish on board. And my ultimate goal is to get her to AHPBA with me because I think she would be a great addition to our group. So, all right, wait, hold on. I am having some technical difficulties here. Oh, there we go. Okay. So just some brief objectives: review the rationale for hepatic artery infusion pump therapy and met colorectal, which is where it all began, and now for intrahepatic cholangio. When do we consider hepatic artery pump treatment? Go over the pre-op workup necessary prior to pump placement. Review some specific post-op issues and regarding to the pump. Pump complications and management, how we do it at least. And then I thought we could have a QA with Trish and myself if anybody has any specific questions or something you've been wanting to ask. So the rationale, really, this whole pump chemotherapy started really with Dr. Kemany with the idea that you could give higher doses of chemotherapy into the liver. And the reason for that is because while the normal liver parenchyma derives its blood supply through the portal vein, liver metastases derive their blood supply from the hepatic artery. So the concept was, okay, if we can get the chemo into the liver first, we can give higher doses of chemotherapy. And because the liver is, so powerful, many of our drugs, especially FEVR, which is the most common intrahepatic chemotherapy that we give, is cleared almost 99% by first pass metabolism in the liver. So it's that whole thing where you get more drug to where the problems are, especially for met colorectal, as many of us know. I mean, we're seeing all these young people now presenting, and in met colorectal, most of the time, the liver is the only place for metastatic disease. So we have liver-only disease with a primary in place. What's a great way to treat that? We could take out the primary, put the pump in, and give high-dose chemo right into the liver. And then, originally when these studies were first published, it wasn't necessarily a thought, but, with good response rates, we are able to convert people from unresectable to resection. So why do we think about regional chemotherapy for these drugs? So like I said, in met colorectal, 15% will have liver disease at the get-go. And people who don't have liver disease will develop 60% of them will develop liver metastasis at some point during their time that they're getting surveillance. In cholangiocarcinoma, which the intrahepatic cholangio is a much newer concept for delivering chemotherapy. We've been thinking about it more and more, but the whole idea really started with met colorectal. And for cholangio, I mean, most of our patients are unresectable when they're diagnosed, you know, just given the involvement of one side or the other of the liver. And there's not great systemic options for intrahepatic cholangio, as you all know. So that was another reason why we thought of, well, let's try to see if we can get the same control with met colorectal, if we can use that same paradigm for cholangiocarcinoma. So what are some contraindications? Like, don't put a pump in. Underlying liver disease, so patients who have very bad, poor hepatic function, you know, we always do check bilirubin, you know, standard LFTs, alkaline phosphatase, especially you have to watch because you have to watch out for a late complication with biliary sclerosis. Extensive tumor burden in the liver. So we generally use the 70% rule. Like if you look at the skin and 70% of the liver has got tumor in it, you have to really worry about those patients, because we have had some patients who they just can't get to the point where you can get the chemotherapy in because their tumor is so burdened already by the liver. Portal hypertension or portal vein occlusion. And this is kind of like metastatic disease outside the liver. There are exceptions. I wouldn't say that we never put a pump in, you know, something very small volume disease or a nodal metastasis that you know, is maybe a soft call, but obviously anybody who had widely metastatic disease outside of the liver, we wouldn't consider pump. And then the last is logistic feasibility in getting to appointments. And I don't know if this is so much of a problem for people outside of New York, but with the pump, they have to, you know, the worst thing is if the pump goes dry. So you need to make sure that they understand and are committed to the fact that they're going to be coming back for chemotherapy, usually once every 4 weeks, and then they need to get that pump fill in between. And that can become a problem for patients who are far away, and especially in big centers like Morgantown and MD Anderson or Sarah at Duke or me at Sloan. You know, people come from far away, and it's like they kind of think of it as like the holy grail of chemotherapy, but then when they start looking at the actual logistics, it becomes a little bit too complicated for them. So what's in the pre-op eval? So just like any other patient we're going to take to surgery, it's a high quality cross-sectional imaging. We do CT angio with reconstruction of the hepatic arterial anatomy. It's not to say if they don't have standard hepatic arterial anatomy that it's impossible. It just makes the surgery a little bit more complicated. You want to confirm their pathology so you know what you're putting the pump in for, right? You just don't want to get fooled that it was something else that you thought was one thing and then it wasn't. They have to be able to tolerate general anesthesia. Obviously, it's generally a laparotomy, but can be done minimally invasive, robotic, or laparoscopic. And like I had said earlier, the real extensive patient education and family education about coming into the appointments, collaboration with medical oncology, which that's why Trish and I are giving this presentation together. We're constantly back and forth. And especially in patients who have had neoadjuvant treatment prior to planning to do resection and pump, you need to make sure that we're holding the systemic chemotherapy prior to surgery. And then just for the newer programs, like institutionally, what does your institution look at as far as nuclear medicine's ability to do these hepatic flow scans, interventional radiology to do a pump study and also embolize any aberrant anatomy, and then just the constant collaboration back and forth with surgery and medicine to make sure patients are going home with their pump filled, with an appointment, when they're coming back, so they understand kind of like the whole deal. This is a very nice picture we got from Dr. Kemeny that shows, this is our classic CT angio that shows the pump is put into the GDA, which is right here. You have your common hepatic proper and then left and right. So they place the pump going up into the GDA, and then you get your liver, your perfusion right into the both. Well, depending, sometimes they take one of those arteries if they're doing surgery, but by putting it in the GDA, you get preferential treatment only to the liver. And they will go in and seal these like little tiny little vessels. They try to cut those off and ligate those when they're putting the pump into the GDA to make sure that we don't get these aberrant perfusions to other places, because that would be bad. Intraoperative considerations, cholecystectomy always done, if not done previously. You don't want to give chemotherapy into the gallbladder, they get super sick. It can be combined with resecting the primary and metastatic disease. So, you know, a typical operation for us would be somebody comes in met colorectal, they get a few months of chemotherapy, they might, if their primary is not out, they would get their primary, partial hepatectomy, placement of the pump all at the same time. But it could also be part of a planned two-step procedure. So say they're not resectable in the beginning, but we think we could go in, put the pump in, give them adjuvant, and then hopefully downsize them to a potential second stage resection. And those are usually combined with ablations and whatnot. In the OR, they use methylene blue, and they test it and inject the side port, make sure that the pump is only perfusing the liver. If they see extrahepatic perfusion in the liver, they can go ahead and ligate those aberrant vessels, but we always wind up having to check the pump study postoperatively anyway. And then antibiotics are not necessarily necessary, just like postoperative antibiotics are not necessary for pump only. Obviously, pre-op antibiotics as per your institutional guidelines, but if you're only putting in a pump, you don't need to give them a prolonged course of antibiotics afterwards. And this is just also Dr. Kemeny slide here that shows the pump placement into, you can see it, they're tied right there into the GDA. And it normally sits, we generally put them in the left lower quadrant, just because that's like a good angle for where the catheter is. Occasionally we've put them in other places. So post-op, the way I always used to tell students or even residents or whatever, whenever we were taking care of a fresh post-op patient with the pump, and even afterwards when they come in on admission, is that always just keep in your back of your head that it's an abdominal procedure and a vascular procedure, because they are putting a catheter into an artery, and that catheter stays in that artery for the duration of the time that the pump is in place. So a bleed later on can happen with pump chemotherapy. So if somebody comes in and they're looking a little bit not right, is it septic, is it this, is it that? With the pump placement, bleeding always has to go up on the top of your list, even after the initial post-operative period. The pump pocket, the elusive pump pocket hematoma. I used to hate that when I'd walk in on rounds and then you'd see like the kind of like big flank area looking a little, you know, black and blue. An expanding pump pocket hematoma is obviously an emergency, needs to go take back to the OR right away. They have to get that clot out. And then just with any other surgery, you know, like infection, just for the pumps, we have a super low threshold for starting IV antibiotics. Like you want to get on it right away, because the last thing you want is to lose the pump because of infection. And I will say, like, if the pump ever does have to come out for some reason, whatever that may be, the catheter always stays in place. They just tie it off and leave the catheter in place, because the catheter is intra-abdominal, and then it terminates in the pump pocket, which is extra-abdominal. The nuclear medicine pump study, we always do one. The standard was always that we did it before the patient left the hospital. With some of the laparoscopic pump onlys that go home on like day, optimistically 2 or 3, that we have done some in the outpatient study, but it really makes us more comfortable to get it in the hospital. This way we know what we're dealing with when we're in the outpatient study. And the other thing is you want to just make sure that the pump is filled, like especially somebody, they'll fill it in the OR, but that only lasts about, I think, 10 days. So you want to, a lot of times what we would do in the hospital is empty the pump and fill it again. So that buys the patient like another 2 weeks before they have to come in for another pump fill. This is just a normal pump study. You could see that it's like, it's treated, here's where the catheter would be, and it's filling, perfusing the liver only. If it's abnormal, you'll see like a area of perfusion down here by the pancreas or duodenum, which that needs to be fixed before you can put heparin and saline in the pump. If it's an abnormal pump study, you just cannot put chemotherapy in. So now what are you doing at the abnormal pumps studies? Most likely it's the cause is a small branch vessel that was not ligated in the OR. This is where our interventional radiologists come in, and they can do a pump angiogram and embolize the aberrant vessels. So they can see where the pump is misperfusing, and then they go in and block off those vessels. Occasionally we have to do a regular standard angiogram or arteriogram as well. But this is a trick that Trish taught me, is that always after embolization to repeat the pump study to make sure that whatever they fixed in IR actually worked. And occasionally there is like a vessel that just can't be found. And in that case, we would repeat the pump study in like 4 weeks and see if it just kind of settles out on its own. There is some cases that the pump just doesn't work, and patients have to know that beforehand. We tell them at the pre-op visit that there's a chance that we put this in and for some reason it just doesn't work. Another complication, or not complication, but thing that can happen is occasionally you could just get perfusion to just one side of the liver. And again, they could try an interventional radiology to try to like alter the blood flow so that you get cross perfusion. This also sometimes improves itself over time. You just develop collaterals and they'll get like left or right flow or whatnot, but you can still treat if it's only perfusing one side or preferentially perfusing one side. But it's not obviously ideal, because then you're giving more to like the left and what if all the disease is on the right, and etc. So other pump considerations that we think about is a flipped pump. And I don't know if you guys have had this, but this normally happens in obese patients, actually in patients who we think that there's a high risk of the pump flipping. But I mean, they're tacked down to the abdominal wall, but occasionally they can flip on themselves. And the surgeons can flip them back, but I would not do that myself, because it's hard to know which way the catheter is in regards to the way it's plugged into the pump. So it's really one of those things that when they put it in, they're the ones that need to flip it back. They can try to flip it back in the clinic. We've done that with Dr. Allen a couple of times when he was up here. And in order to avoid the pump getting flipped, we sometimes will put it up on the chest wall, which is kind of hard for patients because it's literally on their rib cage, but it's better than your pump constantly flipping and having to sometimes even go back and have to have it revised. Biliary sclerosis is a known complication of hepatic artery infusion chemotherapy. This is where Trish and her team really are so on top of the patients, because they're constantly trending bilirubin, alk-phos, AST, ALT, and they can obviously make changes in the dose, or sometimes patients will just get systemic and skip a cycle of pump and then go back. Another way to treat this, if you're highly suspicious that this is what it is to put Decadron in the pump, both during treatment and also afterwards. If you think the patient's developing a late-term like sclerosis or stricture, that's a treatment that could be used for that. And just patient education, no alcohol while they're on pump chemotherapy at all, because you're really bombarding their liver with chemotherapy. They need to be careful about what other things they're doing, hot tubs and things like that. So a few cases. This is one of Dr. Kemany's slides that she shared with us. This was a 53-year-old person with metastatic colorectal, began treatment on your first scan, this was pre-baseline. So multifocal disease kind of scattered throughout the liver. And this began hepatic artery FUDR dexamethasone with CPT-11 oxaliplatin, dropped their CEA to 2.9, and this is their follow-up scan. And then they wound up going on to get resected and ablated following this. This is one of my favorite patients on the planet. I actually pulled her scan up today to put this in the presentation. She was 34 years old, diagnosed with stage 4 colon with widespread liver disease. I mean, she had these like everywhere. So, but it was pretty much right-sided dominated. So we wound up for her, she got systemic first, full Fox, then a right-sided PVE, then went back about 6 weeks after the PVE and got right hepatectomy, pump, and resected the primary. And that's her scan. That was her post-operative scan, but I actually just looked at her scan from November, and she's NED. And the great story about her is that when she was about 2 years out or 3 years out, she wound up getting pregnant, and she was like 37 years old and obviously didn't think that she was going to have another baby after having gone through chemotherapy. But her little girl now is like 4 years old, I think, and she's totally NED, which is like a little feel-good story. Everything's so crazy. We all need a little feel-good. And I just wanted to show you guys this. I actually just pulled this into the presentation today too, because this is somebody that we just saw, or we saw her literally today. So this is a lady with Hep C, 58 years old, treated, who actually had been getting surveillance and then wound up getting this scan. This is actually being read as a pancreobiliary primary, so it's likely the immunohistochemical studies are coming back more supportive of a cholangio. So we consent, she's chemo naive, she hasn't had any treatment yet. We're gonna put the pump in, and hopefully the reason why I wanted to show this scan is that with these cholangios, she's got a lot of caudate involvement, you can see here, and then there's like central, like lobulated typical cholangio, and she's got some satellites over here. But the problem with the cholangios is they tend to shrink down. So while you get this really good response, it's like the response in the place that you don't want. So instead of them shrinking away from the hilus, they kind of shrink right on top of it. So sometimes, even though the tumor can go from something like this to basically nothing, they still wind up being resectable because it's just a smaller tumor and still a really bad spot. This was my references, and then I just thought we would open it up. Having Trish on the call is like a great resource if anybody has any questions for Trish, or I know there's some newer pump programs if anyone has anything that they want to ask her. I thought it would be nice to introduce her to the group from a medical oncology perspective.
I'd say at UT Southwestern, we're relatively new in terms of not having the volume, some of the other centers. In your centers, who is the person who actually accesses the pump for the FUDR and the heparin?
Our chemotherapy nurses are trained for the pump chemotherapy administration.
Do any of the doctors are on standby in case there's any issues, or is it all chemotherapy nurses?
It's all chemotherapy nurses as far as the administration. The only thing is, like Jenny had discussed earlier with the flipped pumps, which they do happen, with the patients, who a little more obese, that is something where they would be called. Most times, once it's flipped, they do have to go back and have it surgically, resutured. Because it can be a constant problem, and the issues of FUDRs in the pump, and we can't remove it, you're risking damage to the liver if there's extra days of FUDR in the pump.
And Lan, I will say for the initial access for the SPECT CT, I'm accessing, because there's the two ports, there's that central port that the chemo nurses access, and then the lateral port that we have to access for the technetium study. I'm accessing them for the initial study. If their BMI is 30 or less, we find it's really hard to palpate that port site on the obese patients. So if either it's not my shift, or if their BMI is over 30, then we've been sending them to IR. But then we typically don't have to access that port site again, assuming all goes well. But like Trish said, we've had great chemo nurses who do all the rest of the hard work.
And for the initial flow scans, I know that we have 2 nurses, they're clinical nurse specialists in nuclear medicine who actually, they are the ones, only 2 really that do the flow scans. And if they can't access it, because you're right, it is more difficult with the Medtronic pumps to access that side port. So they sometimes do have to go into interventional radiology then, and then it would be the physician.
First, I want to thank Jenny and Trish for the presentation. I think it was a great overview, and I actually love that article that you sent, and I shared it with some of my colleagues. So thank you so much. I just have a few questions because, as you know, our program is much newer than yours, and we utilize your expertise often. Which pump are you using now? We've recently had some of the 40 ml reservoirs, which has actually been kind of nice because patients have had a little bit more leeway depending on their pump fills, et cetera. But what are you guys currently using?
So most of our patients have the 20 cc's. I know that there was a period of time where we do have a few patients that do have the 40. However, even though they have a 40 cc reservoir, we've still been keeping with the 20 cc fill, you know, as far as, because then the calculation and all that. So we've been keeping with the 20 cc fill with the chemotherapy, even with the 40 cc pumps.
Yeah, because to your point of the travel, we try to get them back within 12 to 16 days. And so that's been a little bit challenging at times. But.
Yeah, and that's, you know, as Jenny was talking about in the beginning, really having a frank discussion with them about keeping on the every 2-week schedule, 14 days, especially with have the chemotherapy in. It's really, really important. There is that little bit of leeway when you have the heparin and saline in, but with the 20 cc's, you really, there's only so much unless you drop the rate, which we have done with patients who are off chemotherapy and are on surveillance. We've gone down to an every 3 week with a 0.7 rate.
And I was just curious, how many of these are you guys doing minimally invasive, either robotic or laparoscopic?
I don't have the number, but I don't feel like it's that many because I feel like it's always combined with something else. You know, like it's typical probably for everybody. I think our newest attending probably does a little bit more robotically. I know Dr. Kingham does a lot of robotically, but if it's combined with something else, because normally they're constantly thinking like, well, we could ablate this, do this, put the pump in, and then go back for another time, you know? I don't think it's that many, but we have done them, but it's still the same operation, even though the incision is smaller. Trish, do you know?
I would say probably, I would say almost a handful.
Yeah.
You know, every month, maybe every 2 months, we'll have a laparoscopic or because like Jenny said, a lot of times when we have these patients, we're doing a colon resection, plus we're, you know, putting a pump in. But I mean, we do have patients who have a large burden of liver disease. We're putting the pump in and we're trying to get them treated as quickly as we can.
That was a nice overview, Jenny. I really like that.
Yeah, thanks guys a lot. We don't do this at Anderson at all. So it's kind of nice to like have you guys explain it from like bottom up, because I got it. I understood it perfectly well for someone who we just don't do this at Anderson. I just found out.
Yeah, you know, it's interesting because like I said, Trish and I have been in this for a while. So it wasn't always like well received, I guess is the best way to put it. It wasn't, there was a lot of criticism in the beginning. And then just, I'd say in the last probably 10 years or so, it just seems like all the fellows were going out to their respective new places of employment. And then, you know, like a year or so in, they're getting the institutions are on board with starting these programs, which is kind of where I got this idea to bring Tricia in, because I was like, it's just, we've been doing it for a long time, but it wasn't always in fashion. There was just some people that were just kind of opposed to it. And it really does require like the strict following that Tricia and Karen and Sandy are doing with these patients to prevent any of these complications.
And it really does, it takes a whole multidisciplinary team to really get these programs up and running. And that's why when we did have, I mean, I would say this year has been rough with COVID. So of course we haven't been able to have any visitors, but for the 2 years prior to that, I mean, I would say every other month, you know, there was someone definitely interested in coming and learning and starting these programs. And we would have the physician, and then we would tell them, bring the physician, we want the nurse, we want the office practice nurse, we want the chemotherapy nurse, because that's the only way it works, is if everybody's working together.
Hi, this is Kristen Ois. I don't know if you can see me. I'm a PA at University of Colorado Hospital, and I think I met a few of you at the AHPBA conference last year or earlier this year. I just wanted to comment that we started doing these at University of Colorado, I think about a year ago, but then COVID put a hard stop to it. And I wasn't personally involved. I have a liver colleague, and I would love to share this presentation with her if you're able to share with us. And thank you so much for a great talk.
Yes, I can send my slides to Jill, and I'm sure she can get them out.
Absolutely. I'll also include a video, a copy of this presentation. So, great question.
Anyone else have any questions?
I guess just one last question while we have Trish, because you're just a fantastic resource, and we're so happy to have you on this call. You know, everyone always refers to you and your team because it's this like art of managing the pump chemotherapy, and you guys have it down to a science. You know, I used to be outpatient, now I'm inpatient, so I only see these patients in the hospital, and then I of course keep up with our team a little bit. But any overall pearls, how do you know, generally like adjust the dosing? I know, you know, just kind of a broad overview of your teasing apart whether it's biliary sclerosis or if it's, you know, tumor progression. I know we check the LDH and all of those things, but sometimes in my mind it's like this, you know, magic that you guys do on the medical oncology side to adjust these doses for the patients and find the right chemotherapy regimen.
I think the couple things, we do keep these very specific flow sheets. So you're looking at all the lab work, including the liver function test, the baseline day where you start the chemotherapy. Then 2 weeks later, when you're emptying the chemotherapy, you're getting a full liver function panel as well. And then the day you're recycling again. So it's a monthly cycle. So you have 2 weeks with the chemotherapy in, 2 weeks with chemotherapy out. You're looking for elevation on that pump empty day as well as the recycling day. So, and really it is a very specific formula in where if that alk phos, it could be a high alk phos out of the normal, but you're looking at that and you're looking at, is it 1.2 times that reference range? And that reference range is the start of treatment. It's not a normal alk phos. And I think that that's sometimes like a harder, you know, idea to grasp, even within my own institution, you know, questions of, but it's not a normal alk phos. Most people with liver disease don't have normal. So you're looking at that. If it's 1.2 times 1 or 1.5 in between there, 1.2 to 1.5 of the reference, that's going to mean you're going to have to reduce the FUDR, whether it's at the empty or whether it's at the recycle. If it's over 1.5 from that reference range, then you're going to have to hold that chemotherapy. And it's very, very important that you hold the chemotherapy at that time, because that's when you can run into problems of biliary sclerosis. Like I've seen, you know, cases from outside where it just wasn't held, the same dose was given and it wasn't adjusted because of the increase in, especially the alkaline phosphatase. That's really the big one that we look at. And of course, a bilirubin, you know, over that as well. I think that's really the most important thing in trying to prevent the biliary sclerosis, and knowing when to hold treatment, knowing when to reduce treatment. And also, like Jenny had said in the presentation, when you do get these elevated alk-phos, bilirubin, putting Decadron in the pump, I explain it to the patients kind of simply, like the pump, it's basically the liver is irritated and you want to calm it down. So steroids, anti-inflammatory, you're trying to calm the liver down. And it really does work very well to bring those numbers down. And then when you resume chemotherapy in the pump, you're not going to go back to that same dose because we know that that's too much for the liver. So you're going to reduce that dose when you resume after a hold at only 25% of the original dose. So those are like the really big pearls, like, you know, kind of that you need to know, you know, as far as that treatment, because it's the way to prevent liver problems for the patient in the future.
Thank you both very much. Are there any other questions from the group? Okay. Well, if there are no other questions, then I think we'll end this presentation, and I look forward to having this available for reference on our website. And then Jenny, thanks if you can send those slides to Jill. I think this will be spread to amongst many of our colleagues.
Sounds good. Happy holidays, everyone.
Thank you for having me.
Happy holidays, guys.
Thanks, Trish.
Thank you.